Good evening, everyone. I'd like to thank you for joining us tonight. This is the first Guidance Parent Workshop of this 2022-2023 school year. And this evening, we're happy to have Miss Lauren Navarra, our Wheatley School social worker, presenting to us tonight. I do apologize. We just had a delivery over here. But Ms. Lauren Navarra, our Wheatley School social worker, will be presenting to us on the topic of eating and body image disorders among youth. Many of our workshops this year, or in the last few years, have focused on helping our students and families through the stress of some of the trying times that we've been encountering. Tonight, our topic is one that we can encounter with families, with students who are dealing with stressful situations, but not just from external sources, but from challenges within as well. And so Ms. Navarra is going to take us through some of the warning signs that we as parents can look for as we begin to kind of keep an eye on our children and make sure that we're supporting them in every way possible, as well as some steps we can take if we do become concerned that we're seeing some potential signs. What are our next steps? Obviously, forewarned is forearmed, and we want to arm our parents with every strategy possible so that they can support their children if needed. So with that being said, I again want to thank you all for joining us this evening, and I'll happily then turn this over to Ms. Navarra. Ms. Navarra, take it away.
Thank you so much, Mr. O'Brien. Thank you to parents, and a special shout out to Mr. Wiener, our school principal, and Dr. Warner, one of our guidance counselors, for taking the time out of their busy schedule to be here with us tonight. And a special thanks to all of the parents here as well. I recognize that we are inundated constantly with our own personal demands and our work roles and what we have to do for our kids in any given moment of any given day. So I'm very thankful to be here with you tonight. I hope that everybody leaves this presentation with a little bit more information and insight as far as what to look out for, the signs and symptoms of various eating disorders. You'll get a little bit more insight as far as what treatment outcomes look like, and towards the end of the presentation, I'll provide you with some resources.
Ms. Navarra, I do apologize for interrupting. We're getting a little bit of an audio disturbance on your end. I'm not sure if it's the microphone on your computer. If possible, I know you do have a second microphone that you're using. Maybe you could try that. Because we're getting a disturbance. I'm not sure what it is.
Okay. Is this a little bit better?
That is.
I'm hearing a little bit of an echo on my end.
That'll be, you'll have to turn off the speakers on your computer.
Okay. Mr. O'Brien, are you there?
Yes, we have you. You probably can't hear me now, though. You would have to unmute your other speaker.
Okay. Can you hear me okay now?
Yes.
Awesome. All good, hopefully? Yes. Okay. Thank you, Mr. O'Brien, for that. I apologize in advance. I'm working off of two devices here, so if you see me like peering to the right, I'm just trying to look at all of the faces that are with us today. So before we start, just a few things. Please do not hesitate to contact me at any point throughout the school year with any questions or concerns you might have. I really mean it when I say my door is always open to students, faculty, as well as parents. Additionally, if you have any questions throughout the program, please feel free to type them in the chat and I'll do my best to answer them. And if I'm not able to give you a direct answer or an answer that's sufficient, I'm happy to get back to you with that. Just a little background about myself. I've been in the field of mental health for about 10 years now. I started my career in addiction and substance use, where I worked out at 2 outpatient substance abuse and mental health facilities. Within those facilities, I was able to really get a great wealth of knowledge and experience, not just related to drugs and alcohol. If we know anything about substance use and addiction, I usually compare it to the iceberg analogy, right? The tip of the iceberg is typically a substance use disorder that somebody might initially be presenting with, but underneath the iceberg, we uncover many reasons why people are seeking out that survival resource of substances to cope. I mention this because it's not uncommon for me to run into somebody with an eating disorder or a disordered type of eating, which I'll explain what that means in a little bit. Between addiction, eating disorders, various mental health conditions, I would say I have like a pretty good experience for what we're going to be talking about tonight. So again, if any of this is relevant or hits home to you or your family, I really mean this. I'm here. Okay. So we'll get started. Below is a list of the DSM, the Diagnostic and Statistical Manual of Mental Illness and Mental Disorders, feeding and eating related disorders. And at the bottom, you can see the asterisk for body dysmorphic disorder. That's not specifically categorized as a feeding and eating disorder. It falls under obsessive compulsive related disorders, but I felt like it was relevant to connect it to the material that we're discussing today because it does tie into, in some respects, the body image, the self-esteem, and the eating component. And oftentimes we see with individuals who do have body dysmorphic disorder, that comorbidity of anorexia or bulimia, for example. So throughout this presentation, I'm going to go through various diagnostic criteria of the various feeding and eating disorders in addition to body dysmorphia. It might be a little bit clinical, but I think that it is really valuable information. And when we go over each respective eating disorder, I will definitely make mention of those important signs that we want to look for, those emotional and behavioral indicators. So as I mentioned previously, when we're talking about eating issues, we really have to recognize this or conceptualize this in terms of an eating spectrum. So as you can see on the left-hand side, we have intuitive eating, or what I like to refer to as mindful eating, where we're really conscious about what we're taking into our bodies. So we're able to recognize those cues of hunger and thirst and respond to them accordingly. In a general sense, individuals with disordered eating and diagnosable eating disorders, there is a little bit of a disconnect between the mind and body, right? Because those cues of hunger and thirst have been overlooked or neglected for so long. And there's so many reasons why people have that mind and body disconnection, whether it be something like trauma, for example, right? Which I'll talk a little bit about later, right? Trauma is definitely one of the correlates, I guess you could say, for eating disorders and disordered eating. There's a reason why we have to separate, right? When we're exposed to a traumatic event, we do whatever we can, or our minds rather do whatever they can to dissociate or decompartmentalize that event. So oftentimes that includes the somatic or the physical aspects of those events that somebody is experiencing. But it's really, our brains can't just say, okay, I'm going to put all of my negative experiences in a box. By nature, if we're compartmentalizing the negative experiences, in this case, maybe the feelings of hunger or feelings of thirst, we're also numbing some pleasurable feelings as well. So again, I just wanted to speak for a moment as far as like that disconnect. Again, we don't just see that with eating related disorders, but for the purpose of today, just definitely something to recognize or keep in mind. Going back to mindful or intuitive eating, we generally speaking have a positive body image. We have positive self-concept. So when we look in the mirror, in a general sense, we are happy with what we see. In addition to that, we are not using food as a means of coping, right? I mentioned substance use earlier, and I know we're not really talking about drugs and alcohol today, but in a similar sense of how I explore substance use and addiction with curiosity, right? Like, what does this do for this person? How does this behavior protect somebody or allow them to get through? Or how does this behavior act as a means of escape? We can look at an eating disorder in a very similar means, right? It's providing some relief for that person, even if it's just short-term immediate relief. Even if the consequences far more outweigh the short-term gains, we still have to recognize what it's doing for that person. So that's a little bit about intuitive eating or mindful eating. We're going to come back to that later when we talk about treatment. as far as including a nutritionist and really getting a good understanding of what mindful eating means with respect to our recovery. And then in the middle, when we're starting to move towards more abnormal eating, we might fall under the disordered eating realm, which we might not meet the complete diagnostic criteria for something like anorexia nervosa or orthorexia, for example. But it's very important that we recognize these signs early on before somebody develops potentially a full-blown eating disorder. So some of the cues or signs of this is starting to kind of ignore those cues of hunger or cues of thirst, right? Pushing through those cues probably when we shouldn't. We might notice that somebody is developing more of a negative body image. They might be preoccupied with what they're seeing in the mirror, and they might start to participate in some of those checking-related behaviors, which we'll get into when we talk about specific diagnostic criteria. When I think of disordered eating, as you can see on the bottom, it says dieting culture. Unfortunately, and with all the research that I've been reading, especially most recently, there is a very high percentage of people who fall in this disordered eating category. And I could go on for a really long time about how society and social media and how, these influences that we are exposed to really do influence the way that we feel about ourselves, the way that we perceive healthy versus unhealthy foods, our overall behaviors related to food and drink. So as I mentioned, it's really important that we address these concerns as they come up and not to minimize them, because it is a very slippery slope and a quick slope of that if somebody goes from disordered eating behaviors to, like I said, what would meet diagnostic criteria for an eating disorder. In a general sense, too, eating disorders have the highest mortality rate of any psychological disorder. So these are some emotional and behavioral signs of eating disorders. They're not specific to any one eating disorder, but I thought that it was really important to just list and mention. I might add that I will definitely be happy to provide this PowerPoint to any parent or student, for that matter, who would like to keep this for record so that you can look back to this at any given point. So I mentioned some of these indicators or these signs, but when we start to see a shift in those attitudes related to weight loss, dieting, body image, what we're seeing in the mirror or what we're not seeing for that matter, and when those issues become primary concerns or cause clinically significant impairment in somebody's major life areas, that to me is a really important warning sign. And when I say those significant life areas, just to name a few, eating disorders absolutely impact relationships. There is a deep sense of shame that's internalized when somebody is struggling with food or eating, and it often causes isolation, right? Isolation with respect to social events, isolation with respect to any events involving or surrounding food, right? These type of situations are extremely, extremely anxiety-provoking for an individual. And sometimes the anticipation of even going to a place or being around people where we know there's a potential for food to be around could cause somebody to, as I mentioned, avoid the event, avoid the situation altogether. So relationships, as I mentioned, is a major life area. In addition to that, school and work, right? Being so preoccupied with our weight, how we're feeling, being able to burn off or work off any excess calories that we might be taking on, right? If we're having these ruminating, recycling thoughts related to food and our behaviors of getting rid of the food or overcompensating for what we've eaten, right? As we can probably surmise, we're not going to be present in chemistry, for example, or algebra. Right, so these thoughts are really all-consuming. Our mood is also affected, right? I have a slide, in a few slides, as far as the neurological implications of an eating disorder, right? At the most simplest form, eating and food is energy, right? It gives us sustenance. Our brain absolutely needs that. So when we're depriving our brain of the nutrients that it needs, there's going to be consequences for our mood, for our behavior, for our ability to really be present and engaged in our current reality. Something also to look out for, and I don't want to, go through all of these bullets, but if we notice that our child or loved one has started participating or exploring any of these fad diets, and we have to take special consideration into certain cultural practices or beliefs that might include fasting, for example, or vegetarianism. That's not necessarily what I'm talking about, even though I listed vegetarianism or veganism on there. If it's part of a cultural or spiritual practice, that's one of the categories to rule out any type of legitimate diagnosable eating disorder. However, when I refer to these fad diets, I mean in more of an extreme way. So somebody cutting out major food groups, for example. I'm not eating sugar anymore, or I'm not eating anything that's the color white, right? And somebody being extremely rigid in their thinking with respect to this, right? So much so that if we have to stray out of what we consider to be our norm, there's usually very much of an emotional reaction attached to that. So the first disorder I wanted to go over was anorexia nervosa. This is the most commonly diagnosed eating disorder among teens and adolescents. Teen girls make up the majority of people who suffer from anorexia. However, we can all be vulnerable to something like this. It affects young children, teens, as I mentioned, even older adults. Teen girls are the most at-risk group. The percentage of boys suffering from anorexia is approximately 5 to 7%. However, it's still something to take into consideration. I haven't personally worked with any male individuals with anorexia. However, at the facility that I was working at that had a clinician that specialized in treating it, and we had our support group, she did see several males. And one of the things I remember her expressing to me was the rate of misdiagnosis or the fact that it is very much underdiagnosed in males. I'm not sure if that's that plays into like our social norms and what we consider to be typical, so to speak, for girls and boys. But I just mentioned this because it's something that is very much undiagnosed in males. And I'm sure that if we take all of those norms of what we know to be like, I don't know, typical teenage boys or typical teenage girls for that matter, the percentage would actually be a lot higher. In a general sense, we know that women and girls are more expressive, and I don't want to overgeneralize this, but just what research has shown is women are more likely to seek out treatment than men. So we want to also give a little bit of extra TLC to our teen boys. So when we talk about anorexia nervosa, this is an extreme restriction of calories to the point where somebody's body weight is much lower than what would be considered the norm. So often doctors refer to the BMI, the body mass index for this. Body mass index can be a helpful additive to diagnostic criteria. However, for people who might be overweight, for example, or very muscular, their BMI might not translate specifically into their health, to how healthy they are or how not healthy they are. But again, for the purposes of talking about anorexia, if somebody has a clinically significant low body weight. With respect to eating patterns and behaviors, we might see things like somebody having a plate of food and cutting the food into very small pieces so that the person gives the illusion of eating a lot or having their plate filled, right? But in reality, they might have taken 2 bites of broccoli, for example, but the broccoli is just so minuscule, right? And the plate is filled with the food that it might give the illusion, like I said, that somebody is eating more than they actually are. There is an extreme obsession over food, how many calories somebody is eating. There's often these obsessive checking behaviors, as I mentioned, right? Looking in the mirror, grabbing specific body parts. There's a lot of measuring. It can be measuring with a tape measure. That's not uncommon for people to carry around. I've also worked with, I'm thinking of one adolescent girl. She would measure herself at least 4 times a day, and she would use her hand steps, and she would measure her thighs to make sure that any water that she drank or any food she consumed did not show up on her thighs, for example. So we see a lot of this almost OCD-like behavior with the obsessive thoughts about, again, the caloric intake, how I look, how I'm appearing, and the checking, right? The checking kind of puts a Band-Aid on the anxiety temporarily, but it does not provide long-term relief, right? It's kind of this vicious cycle that we continue to go through. When we consider anorexia, there's 2 subtypes, restricting type and purging type. So traditionally, when we think of purging, we might think of binging and purging related to bulimia, for example. But when we talk about purging behaviors, there is no binging associated with it in terms of anorexia. So somebody is still taking in a fraction of the caloric, or the calories rather that they need for the day, but they're participating in those compensatory behaviors to get rid of those calories. We also, as mentioned, might see a restricting type, which when we consider or when we have, I guess, a traditional definition of what somebody with anorexia, what their behaviors would look like, how they would present, it's typically that restricting type, where we don't partake in any of those binging, purging behaviors, typically no laxative use, but it is that extreme restriction. Just some things to look for: dramatic weight loss in a short period of time, a student or loved one beginning to wear baggy clothes that might be atypical of what they would normally wear, and the purpose of that is to hide the extreme weight loss. There is a misconception at times that people with anorexia do the opposite, right? They might wear maybe more flattering clothes or more suggestive or revealing clothes. But we have to remember that this is a major self-esteem and body image and food-related issue. So this person could be 75 pounds and they see themselves as a 300-pound obese individual. So very much disguising the clothes, wearing large clothes not only to disguise the weight loss, but to hide my fat, hide my appearance from other people. It's very much a disorder of I don't want to be seen. We might start to notice fine hairs all over a person's body, and typically, at least in my experience from what I've seen, this is when somebody is in a very severe stage of anorexia. The body actually, to compensate for not having enough fat on the body to keep it warm, the body will develop these very thin white hairs from head to toe. And it almost has an appearance of very light white fur. But you can definitely start to see this develop on an individual. It's called lanugo. And I definitely encourage anybody to, enlist in the help of your doctor. If you feel like something is not right, they can definitely look out for and assess for something like this. As you can see, the last bullet, I just put some co-occurring or comorbid disorders that people with anorexia are often diagnosed with. And when I talk about comorbid or co-occurring disorders, those are disorders that are also diagnosed before, during, or after the diagnosis of anorexia. So we see the highest rates of anxiety and obsessive compulsive related disorders. Because again, when I conceptualize anorexia, I also do see it in a way as an obsessive or as an anxiety related disorder, because it has that mental health component, of those recycled thoughts, that rumination, those obsessions that often we give into and we participate in those compulsions. Also, a very high prevalence of mood disorders such as major depressive disorder and bipolar disorder. high rates of substance use disorders as well. I don't want to overgeneralize, but typically drugs that are stimulants. So a lot of nicotine use, cocaine use, for example. Also, something to mention, trauma and eating disorders very much go hand in hand. As you can see, almost a third of individuals with anorexia are diagnosed with PTSD or trauma-related disorders. Just some long-term impact of anorexia. It really does impact somebody mentally, physically, psychologically, socially, spiritually even. It causes somebody to essentially decay from the inside out. And it's very, very dangerous. The prognosis, we'll talk about the prognosis a little bit later for anorexia, but there is a high rate of recurrence or relapse in something like this, right? The way I look at it, any of these eating disorders, but particularly anorexia, it's a disorder of maintenance. I know I'm making a lot of analogies to substance use. That's kind of where I came from, but similarly to somebody who has an alcohol addiction, it requires lifelong maintenance, whether that be individual therapy, AA and group support, family support. It's something that we have to consistently manage, because if we don't leave it in check, we can relapse very quickly and go back to those same patterns of behavior that we were once involved in. So something to mention is refeeding syndrome. It's a very dangerous syndrome when we talk about individuals with anorexia. So typically when somebody has been malnourished, research says approximately 10 to 20 days without food. If somebody then goes to treatment and is given fluids, for example, or an artificial feeding tube, or is actually fed and given a meal plan, the body sometimes doesn't know how to respond, because their body has almost been accustomed or acclimated to a new normal of starvation. So once we start introducing nutrients into the body, it throws off the phosphates and the electrolyte balances in the body so much that it almost sends the body into a shock-like response. We see confusion, we could see disorientation, paranoia, somebody getting very sick. And as mentioned, this refeeding syndrome can be fatal. As I mentioned earlier, I thought this article was really cool that I came across. It was talking about cerebral atrophy and the neurological implications of anorexia nervosa. So as you can see, the picture on the left is a typically developed brain, and the image on the right is an individual. It was a middle-aged female, I believe, that had suffered from anorexia for years at a time. And as you can see, the shrinkage in the brain and the shrinkage in the gray matter, right? You see a lot more black. I would call those holes, for lack of a better word, right? And that brain shrinkage and that shrinkage of that gray matter has behavioral and emotional and psychological implications. So the article goes into how that could relate to more black and white or dichotomous thinking, like more of that all or nothing, very rigid thinking where we have these set core beliefs and it's very hard to break those beliefs. In addition to that, we have a higher degree of beliefs over our negative thoughts. So being able to challenge our thinking with something like the CBT, for example, which we'll talk about later, might be a little bit more difficult. The beauty of it is, though, we have neuroplasticity, our brains are able to regenerate, and our bodies are phenomenal systems and beings. But again, just emphasizing adequate treatment, proactive treatment, and holistic treatment to be able to address all of the components of any individual person. The next common eating disorder among adolescents is bulimia nervosa. So this is recurrent episodes of binging and purging after eating. And when I'm talking about binging, I'm not talking about when we get home from work and we put on The Office on Netflix and we, I don't know, grab some popcorn and we order a pizza and we have a little bit of a junk food dinner. What I mean by binging is eating a quantity that would typically be abnormal for any individual in a short or discrete period of time. So this could look like eating 5,000 or 10,000 calories in a 2-hour period. It could look like not having 1 cup of ice cream, but eating a whole gallon of ice cream and a chicken and a whole pizza. When somebody is participating in these binging behaviors, there's very much a feeling of being out of control. Somebody is engaging in this, and it's almost like another part of them is engaging in these behaviors, and there really is there's a feeling of an inability to stop. After this person has finished their binge, typically they're feeling very sick, very full. Again, as I mentioned earlier, there is so much of that internalized shame, and that, of course, is triggered after we've had our binge. So, of course, we have to compensate for that binge. Somebody might participate in some of those compensatory behaviors. So that might look like purging, any type of laxative or diuretic use. I'm just thinking of a client in particular and she was using Epicac. So she purchased it from her local pharmacy. Unfortunately, the pharmacist or the cashier didn't question why a 14-year-old was buying a vomiting, inducing substance. But nonetheless, excuse me, she purchased this product, and that's what allowed her to kind of get rid of her food after she was done binging. So I mention that because this is definitely something as a parent or as a loved one that we want to look out for. Like I said, laxatives that, we definitely didn't purchase, that should not be in your child's room or in your child's bathroom. Typically, these binging and purging behaviors occur for at least once a week for 3 months. In my clinical experience and working with individuals with bulimia, it's definitely not happening once per week. It's typically happening at least once per day. And the severity of bulimia, the DSM has criteria for mild, moderate, severe, and extreme. Just an example, a mild case would be 1 to 3 purges a week, and extreme goes to 14 plus purges a week. So from my experience, it's not uncommon to hear somebody purging 20 to 30 times a week after eating. So some signs and some things to look for. Food or food wrappers hidden in something like your child's bedroom. It's not uncommon to see like pizza boxes, for example, or candy wrappers. But when I say these things, I'm not talking, as I mentioned, about one candy wrapper. I'm talking about boxes of candy wrappers, bags and bags of chips, right? And again, this is done as a means for isolation and to keep this hidden, because these behaviors are so shame-inducing, right? That this person has to do or has to participate in these behaviors in secret. Something that I've also seen with some clients of mine are bags of vomit. So you might find something like that in your child's room, under the bed, under a car seat. So again, we really want to pay attention to these warning signs. In addition to that, extended trips to the bathroom, especially after eating. So I had a parent once tell me, we're at a restaurant for 2 hours and my daughter is running to the bathroom 4 times. After, we get appetizers, she goes to the bathroom. After she eats her meal, she goes to the bathroom. After we have dessert, goes to the bathroom. When we get home, she goes to the bathroom. And that was her way of being able to control her binge slightly, right? Because she felt, my client felt at that time that if she could eat smaller amounts and purge, that it was somehow less shameful for her. Something to add, it's definitely its own classification, but I didn't want to spend too much time on it because it's a fairly new feeding and eating related disorder, but it's still something to look out for is diabulimia. And this is when individuals refuse to use insulin because they don't want to gain weight. So they might participate in binging and purging behaviors, but it's not exclusive to diabulimia. Also, a few more things I want to add that are just coming to me. Physical signs that we might want to look for. When somebody is beginning to purge very frequently, they might develop what has been called chipmunk cheeks, because when they are throwing up or vomiting, they might be breaking the blood vessels and the capillaries in their throat and then in their cheeks, and also the stomach acid, so it creates a swollen look in the mouth. So that's definitely a common thing that we want to look out for. Any type of dental issues that are out of the norm, right? Like tooth decay, weakening enamel, many cavities. These are all indications of somebody that might be purging. Orthorexia is a focus on healthy eating. And I put healthy eating in parentheses because this is what is perceived to be healthy eating to that individual. When we talk about orthorexia, it's not to be confused with mindful eating or intuitive eating, where we're having a balanced diet, but we're getting in all of our food groups and we're allowing ourselves to have an occasional treat every now and then. This is an obsession with healthy foods and an extreme avoidance of any foods that are deemed unhealthy. So I just put a few examples here for you. It can be foods with any saturated fats in them, foods with preservatives. I've heard of individuals avoiding foods with specific dyes in them. So a very much a fixation on those food labels and what the labels contain. These individuals also spend a large amount of their time researching about healthy foods, the dangers of things like GMOs, for example, and really it's a real fear with food. Very rigid thinking, as we see in other eating disorders. And in order to be diagnosed with orthorexia, the individual does not meet criteria for other eating disorders. I put this article here. I thought this was really interesting, and I've been coming across more articles on American Psychological Association and PubMed and other websites like that, connecting food allergies to eating disorders and body image. And I thought it was really interesting and relevant to just put just as some food for thought, because at least in my experience, I've noticed that the percentage of kids and even adults, for that matter, that are developing food-related and environmental allergies seems to be increasing exponentially. So I'm not, by putting this up here, I'm not saying that every child who has very specific food allergies and a very limited scope of what they're able to eat will develop an eating disorder. But we just want to be really mindful for these kids that do have things like gluten allergies combined with a soy allergy or a tree nut allergy, right? Because it could add to development of something like ARFID, which I'll talk about shortly, right? That extreme restrictive capacity in our ability to eat foods that we want to eat. So binge eating disorder, eating a significantly large amount of food in a very short period of time. And we can compare a binge for binge eating disorder to a binge with bulimia. It's typically a very discrete period of time, like 1 to 2 hours. And this is an amount of food that an average person would consider to be in excess. Right? This is not extra hungry today, so I'm going to have another sandwich. This is, I'm not hungry right now, I'm feeling upset, so I'm going to eat 4 sandwiches and a gallon of ice cream and a pie of pizza, for example. And with bulimia, or with any of these eating disorders, I should say, there really is that sense of lack of control. And I think it's really interesting and kind of a catch-22 because at the root of many eating disorders, not to oversimplify by any means, but there is such a significant control piece, right? As I mentioned earlier, we have to be curious, right? Like, how does this help somebody? How does this protect them? How does this allow them to cope? Right? Eating disorders absolutely give somebody a sense of control, but unfortunately it's a false sense of control. And over time, not everybody who struggles with something like an eating disorder can recognize it and maybe gain that insight. However, there really is that sense of this is completely out of my control. So when we talk about binge eating disorder, that absolutely applies here. And as I mentioned, we're not talking about eating when hungry, right? Like we talked about earlier with the spectrum of eating disorders, there is a disconnect between those cues of hunger and thirst. So somebody is eating to really cope, eating when they're upset, eating when they have a bad day at work. If you've ever seen My 600-Pound Life, for example, if you want to get great insight into somebody who's really experiencing and suffering from binge eating disorder, it's a really great depiction. There's one individual I'm thinking of. You can look her up. Her name is Gina. And she actually had really great insight into her binge eating disorder, how it started because of her childhood trauma. But, you know, as the episodes progress, you can see and you can feel her pain as far as how shameful it is. I know I keep saying that, but it's so profound, the suffering that these individuals are experiencing. And she would consistently mention that throughout her season. And unfortunately, she wound up passing away of complications related to obesity and binge eating disorder. But she would say that she would seek food out as a way to feel happy because it was the only thing that made her happy. But there was such a lack of control over eating that every time she would finish binging, she would almost break down. So if you'd like a show to gain some insight, just one little nugget for you. Similarly to bulimia, but without the purging, this behavior occurs at least once a week for 3 months. But typically from what I've seen and what I've heard, the binges are much more frequent than that. I've heard of people having binges multiple times a day, for example, in extreme cases. And we first start to see binge eating disorder arise in late teens, early 20s. We might see similar signs or indicators with binge eating disorder as we do for something like bulimia. So, for example, we might find hidden wrappers, big bags of fast food takeout, with just wrappers in it, shoved under somebody's bed or under the couch. There might be a hesitation with taking out the garbage, for example, right? That individual with binge eating disorder might feel like they need to have that chore. And if we think about why, right, if we get curious, it's so that they can hide what they're doing and what they're eating, right? Because if somebody were to see the gravity of what's in my garbage can, I would be judged, right? So as you can see this picture on the right, very much full body impact. I just want to see how we are on time. Okay, great. So avoidant restrictive food intake disorder, or ARFID, I would say more common in young children. This is a lack of interest in food. Some people eat for pleasure, some people eat to nourish themselves. These individuals really are avoidant of the whole experience of food and eating. And this could be based on certain sensory characteristics, for example. I don't like eating crunchy things. I don't like the sound of myself chewing on something crunchy like peanuts, for example. With ARFID, we might see some misophonia as well, which is more of that sensory component, where somebody cannot physically tolerate chewing or being around somebody that's chewing. So we do see a little bit of that at times with ARFID. There's also, or there can also be, real irrational fear about eating. So I don't want to eat this food because I'm afraid I'm going to choke on it. Peanut butter, for example, or almond butter is something that's common with ARFID, or that I've heard with ARFID, right? I cannot eat peanut butter because I'm afraid it's going to get stuck in my throat and I'm going to choke to death. Or I'm afraid to eat gluten, even though I may or may not have a gluten allergy, because I'm afraid I'm going to have an allergic reaction, my throat's going to close up, and I'm not going to have an EpiPen, and I'm going to die of this allergic reaction. The difference with ARFID compared to the other feeding and eating related disorders is there is no shape or weight concern. It's more specific to the structure, I guess, of food and the characteristics of food itself. Just two more eating disorders. I would say they're typically less common in terms of like the general population of like youth and adolescents, although they are still important to mention. Pica is the ingestion of materials that are not, that don't provide nutritional value whatsoever. So you might see somebody eating chalk or soap, laundry detergent, string, wool, something like that. And this behavior goes on for a period of at least 1 month. And this behavior is not appropriate to any developmental milestone. So typically to be diagnosed with pica, a child has to be over the age of 2 because we have to see if that child will move out of that oral stage. Right, prior to 2 years old, there is a little bit of that oral fixation where children are putting everything and anything in their mouth. So we have to be able to rule that out to determine if it's a typical developmental milestone or it is indeed something like pica. Again, not to overgeneralize, but typically we see something like pica and rumination disorder alongside individuals with intellectual or developmental disabilities, for example. We can also see it in people with on the autism spectrum. And rumination disorder is repeated regurgitation of food for at least 1 month. So this is not purging where somebody is ingesting the food and throwing it back up or using laxatives or diuretics. This is generally more contained in the mouth. So somebody eats or chews the food, gets the taste, spits it out. They might try to eat it again, chew it, spit it out. And in order to be diagnosed with rumination disorder, the behavior, again, is not typical for any milestone, any young age. It's typically diagnosed over 2 years old. I actually think for rumination disorder, it might be closer to 4 if I'm not mistaken. But the regurgitation of food cannot be attributed to another GI condition. So if somebody has GERD, for example, or heartburn, their spitting up their food could not be a result of that, right? That something like that has to be ruled out. And again, as I mentioned, both of these disorders fall along occur mostly with individuals with intellectual disabilities. Not going to spend too much time on this, but there is a category other specified eating disorder where an individual might not meet all of the specific diagnostic criteria for any one disorder, but their pattern of disordered eating and their thoughts and their behaviors related to food and getting rid of food cause clinically significant impairment. And as I mentioned earlier, this can be in the form of relationships, school, work, maybe even finances, mental health, physical health, of course. So body dysmorphic disorder is not a feeding or eating disorder. Again, I felt necessary to put it in this PowerPoint because we're seeing much higher rates of body dysmorphic disorder than in the past. And I can go on about how social media and worldly and external environmental influences, impact how we see ourselves, but individuals with body dysmorphia do not see what we would see of them in the mirror, right? There are many of these perceived flaws that an individual feels like they are hideous or they look like a monster. And the things they point out typically cannot be observed by another person. So, for example, an individual's body dysmorphia may say, my skin is absolutely terrible. I have all these marks on my face, can't you see? And their skin could be beautifully clear. Their complexion could be blemish-free. But in their mind, they see these flaws and they're highlighted in their minds. I also put body dysmorphic disorder because anorexia and bulimia specifically are two major comorbid or co-occurring disorders that someone can be diagnosed with and often is diagnosed with when they are in treatment or, receiving treatment for body dysmorphia. So as you can see, just some stats on, again, social media and how that impacts, body image and eating disorders. Everything is photoshopped, so we are comparing what I call our real selves to what I refer to as everybody's digital selves, right? This facade that we put up on social media for the world to see, right? That don't show any of our stomach lines, which we all have, that don't show our wrinkles, that always display us having the best life ever, and we're just so happy and so perfect all the time. If we consider a young person, a teenager, right, and the developing brain, we are so highly influenced by the messages that we receive. So parents, I encourage you to just really hit these points home at home. I can't stress that enough. Really have these conversations about reality and fantasy, right, when it comes to what we're seeing on TV, what we're seeing in the world as far as the digital world goes. I just thought this slide was interesting. We've been talking a little bit about disorders that are often co-occurring with any specific eating disorder, but these are the most common mental health disorders that can be found alongside an eating disorder. There is no one set cause. Rather, it's more how all of these factors influence and kind of interweave in making up who any given individual is. So research shows that family history is a very significant predictor of somebody developing disordered eating or even a diagnosable eating disorder for several reasons. There are specific brain areas that have been linked to eating disorders and depletions or reductions in certain activity in brain areas and those neurotransmitters. When we talk about family history too, I also think about the norms and the behavioral aspect of family history. And what I mean by that is kind of the culture that we're reinforcing in our home, right? What messages we're sending in any given day to our children about what food is, the purpose of eating and nutrition, the importance of it, right? And one of the things I want to make mention of is even how we talk to ourselves. Excuse me. We don't think that children are listening, but they're sponges. They're hearing what we're saying, and they're also hearing what we're not saying. We could say, I feel great about myself, but if the child sees you tracking yourself in the mirror and sulking and not being happy with how you look, they're absolutely going to take that on. So just something to make mention of. Other mental disorders, right? We kind of went over those a little bit earlier. Depression, obsessive compulsive disorder, trauma, right? This is a means of coping. Dieting and starvation as well, So we talked about that earlier, how dieting affects the brain, particularly with anorexia. But if we're starving the brain of energy and nutrients that it needs, our brain is not going to work in the way that it's intended to, right? So that might lead us into participating in more of those unhealthy behaviors. And just some personality factors related to eating disorders, low self-esteem, high levels of neuroticism and perfectionism, for example, impulsivity, and control, of course, right? This control is such a big piece, like we talked about earlier, right? The need to feel like I'm in control of something in my life because everything in my life feels so out of control. When we consider treatment is extremely complex, and I wanted to list the percentages of individuals with anorexia and bulimia specifically, just because those are the two main eating disorders that we do see among children and adolescents. And as you can see, the treatment outcomes vary, right? 46%, for example, of people with anorexia meet full recovery, and 20% remain chronically ill, 20% give or take. Again, as I mentioned earlier, these are diseases of maintenance, right? Often somebody goes through this cycle. I can refer to like the stages of change, right? Where somebody prepares to make that change. They initiate that change. And sometimes part of the stage of change model is relapse, right? Sometimes it takes somebody 7, 8, 9 times of relapsing to be able to be in full remission, for example. And remission, clinically speaking, when we talk about eating disorders, is not participating in any of these extreme weight loss measures, counting calories, compensatory behaviors for at least 6 months. So that would be partial remission, and then full remission would be at least 1 year. But these disorders that we're talking about are some of the most complex mental health disorders that we can see and treat. So treatment in that sense must be very complex and very holistic, involve many different disciplines, different modalities, different systems, whether it be professional systems, but also interpersonal and family systems. So I could probably go on for 3 hours about all of these different types of treatment. If I may share, my personal favorites are DBT, internal family systems therapy, and any mindfulness-based practices. Mindfulness is a huge component of eating disorder recovery and goes along the lines of that idea of intuitive eating or mindful eating, really changing the way we look at, we perceive food and ourselves. So in short, I'll just, highlight a few benefits of each of these treatments. CBT focuses on thoughts, behaviors, emotions, and really allows that person to explore feelings when they arise, right? Explore those triggers and how their emotional states relate to some of those maladaptive behaviors. For example, binging and purging. Internal family systems therapy is really, really cool. It's used for a wide variety of clients, from trauma to eating disorders to substance use. It's really interesting. The creator of IFS, Richard Schwartz, started his career treating individuals with eating disorders, and now he's a prominent figure in the trauma world. But he created this therapy called IFS, or also known as parts therapy or parts work, because throughout the treatment he noticed similar verbalizations from his clients. Things like, when a part of me takes over, that part of me just goes to the fridge and eats everything, and I have no control over that part, right? That part of me, and then when that part of me goes away, this other part of me comes in and beats me up. Or this part of me is so controlling and, counts my calories all day and makes sure that I remember to weigh myself 10 times a day, for example, right? And when we talk about parts, it's not pathologizing anybody. One of the amazing proponents or core values of IFS is that everybody has parts, right? It doesn't mean that there's anything wrong with us. we're all complex and multifaceted in nature. And to really be able to treat these disorders, we have to get to know ourselves. And ourself is a culmination of all the parts of us. So as you can see on my picture, the different types of parts, and if you're interested in something like that, or any of the other concepts that we've spoken about today, again, by all means, I hope you can see I'm very passionate about this stuff. It's something that is really important to me personally and professionally, so I'm always happy to share any resources that I might have. DBT is great too because it incorporates that mindfulness piece, and when I think about DBT, I like to think about it as one skill building on another. So we establish those mindfulness-based skills to gain more self-awareness. We develop those emotion regulation and distress tolerance skills so that when we start to become more self-aware, right, we talked about the disconnect of the mind and body earlier. So when we're working on becoming more integrated, it's totally normal and to be expected that the body feelings and sensations and the emotions that we have are magnified times a million. So those skills are so important when those feelings do come up, to be able to reduce that stress and to help build somebody's window of tolerance so they are able to sit with the feeling a little bit longer, to process things, right? Process why, the reasons why they're even seeking out food in the first place, to be able to process those food-related urges of, I'm feeling an emotion, I need to binge, or I'm feeling really guilty, I need to go exercise, I need to purge. And last but not least, DBT skill, interpersonal effectiveness. Eating disorders are not technically considered to be a family issue, although I feel that family is really such an integral part of somebody's recovery, just across the board. So interpersonal effectiveness helps with those relationship skills, assertiveness, and boundary setting. So for some prevention, what you can do, and I think we've talked about some of these concepts earlier, we definitely, as much as possible, want to avoid dieting in front of our children. And I should have prefaced this slide by saying I'm never giving parenting advice, always friendly suggestions. So please take what you want out of this slide, whatever is relevant to you, along with the other slides that I've shared today. In a general sense, as I mentioned, our kids are shaped by what they see, right? Their life experiences. So if we have a culture in our house that is focused on really extreme healthy eating and exercising and weight and how do I look and how does this look if we're eating so much, right? Our kids are absolutely going to take that in and internalize that. And I think sitting at the dinner table is maybe one of the few moments that we have with our kids at home, maybe the only moment of peace that we have throughout our day. So I really think it's so important to cultivate and reinforce that time as much as possible. And I absolutely recognize, I'm not a parent, but I recognize that as a parent, you have 12 hats that you're wearing at any given time, so it might not be realistic to sit down every night and eat a meal together. However, even if it's just a snack together, right, or even if it's once a week, that everyone can get together and just share how the week went, share our thoughts about a meal together. That's really how we cultivate and reinforce things like intuitive eating and having a balanced diet. As I mentioned with the body image and social media and those outside influences that we talked about earlier, really open up the conversation. Even if your kid says, this is annoying, I don't want to talk about it, you're still planting a seed for them. So don't be afraid to discuss things like diet culture, or what we're noticing on TV or social media, or those ideas of perfectionism that we're fed so much in society, right? It's those honest conversations that will open the door and that will keep it open so that your child can continue to come to you if they have an issue about something like this. Of course, cultivating a positive body image, right? Avoiding as I mentioned, putting ourselves down, but also avoiding putting our child down when it comes to their appearance, their weight, maybe even what they're wearing. And of course, ask for help, right? It's okay to ask for help. To me, asking for help is a sign of maturity and awareness, right? Because we can recognize that we're not feeling our best, or we can recognize that maybe as a parent, I can take my child up to here, but I need to pass the baton to a professional. And that doesn't mean that, you don't care as a parent. It just means that I don't have the clinical skills or the medical expertise to be able to handle this on my own, and I need the help of a team. Last but not least, I wanted to include some community resources. So I included my phone number and email at the top. As I keep mentioning, please do not hesitate to reach out. It's always a pleasure when I get to speak to the parents of one of the children that I may come across in any given day. So anything you need, I'm here. Mr. O'Brien is here, the rest of the guidance department. Monte Nido is a wonderful, very reputable inpatient treatment facility in Glen Cove. It's right by the Glen Cove Golf Course, if anybody's familiar with that area. But they turned this brick mansion into this amazing facility where they really take a very holistic approach to treatment. And they have this wonderful yoga room and a creative art space. I was fortunate enough to be able to take a tour of that facility. So I do have a little bit of a connection to Monte Nido. Like I said, don't hesitate to reach out if I can ever make a call for you or pick someone's brain about treatment, cost, anything like that. ED 180 is a practice in Garden City. It's run by Dr. DeSarbo, who is a real main prominent figure in eating disorder recovery. He's an amazing person and psychiatrist, and if you ever could hear him speak, I really encourage you to, especially if you're interested in this topic. So he provides psychiatry and medication management. He also offers group therapy, nutrition, and biofeedback, which is really cool, which involves, it's a non-invasive procedure, I guess you could say, where it involves stimulating the different brain waves to encourage neuroplasticity and to just, it's kind of like an additive, I guess you could say, or a supplemental treatment to traditional like individual and group therapy. Mather Hospital is wonderful, have referred there many times. They have many different levels of program, from intensive outpatient, which is typically 3 to 5 days a week, at least 4 hours a day, to a partial hospitalization program where a student, for example, could attend their school day for a part of the day in the morning and go to the partial in the afternoon. And they also have an inpatient program for individuals who I don't want to say are in that meet extreme criteria for eating disorders, but that need to be medically stabilized before they're able to kind of be more independent in an outpatient setting. Newport Academy is wonderful. They're a residential and inpatient treatment facility that serves, they have a teen girls facility and teen boys facility, and one of their specialties is also eating disorders. They're in Connecticut, but amazing place. And last but not least, BICAD has an eating disorder support group. Joanne Devitt heads it up. She is an amazing colleague and clinician. She does typically serve individuals over 17. However, in some cases, she is known to make an exception. She will see individuals for therapy under 17, but I just felt that it was necessary to put this resource because I'm sure that we might know somebody that's struggling that is maybe not a child or an adolescent, right? Because as we've talked about, all of us can be vulnerable to an eating disorder. So again, I thank you all so much for being here with us tonight. If anybody has any questions, please feel free to ask.
we can take questions in the chat as well. I'd also like to take this opportunity to thank you, Ms. Navarra, again for your time and talent this evening. The information you provide is always well appreciated and well received. I'd like to thank you, Mrs. Piscopi. I'd like to thank Mr. Weiner, our building principal, again, and Dr. Warner and Ms. Silverstein, our school counselors, for joining us, as well as all the parents who took time out of their evening to join us as well. Tonight's presentation has been recorded. It will be posted on the Guidance Department YouTube channel and shared out with everybody sometime by next Tuesday at the latest, as well as the slides from this presentation, which will be posted on the Wheatley Guidance website, as well as also shared out with the parents. That being said, if there are no other questions, I'd like to thank everybody again for joining us this evening. Thank you all so much. Have a wonderful evening and an even better weekend ahead with your families. Thanks, everyone, and take care.
Good night.
Be well.
Bye.
Good night.